Okay. Good evening, everybody. On the behalf of the TME team and coordinators, I welcome you all for the 8th edition of this month in Endoscopy. Today we have two eminent panelists, Professor Ramakrishna sir. He is retired professor from CMC. Currently, he is the Director and Chief Gastroenterologist at SRM Institute of Medical Sciences at Chennai. He is joined by Professor L. Venkatakrishnan sir. He is Professor and HOD, Department of Gastroenterology at PSG Hospitals, Coimbatore. So today we have Dr. Manas Makumar Panigrahi, Associate Professor from AIMS Bhubaneswar, going to present for this session. Dr. Manas, please.
Good evening, all. Thank you, Ramakrishna sir and Venkatakrishnan sir, for this, for your presence, and in your presence we are presenting this time. So, and this month endoscopy, that is March 2022. I'll be going to present 4 journals: one from endoscopy, one from colonoscopy, one is ERCP and US. First journal, that is on endoscopy, is on direct endoscopic necrosectomy. On colonoscopy, I will be discussing on a bowel preparation journal, and there is a randomized trial on double guide wire versus single guide wire technique in ERCP, and the role of Rose, that is Rose in US. So, journal and endoscopy, this is published this month in gastrointestinal endoscopy, and this is a study from this is a multi-centric study, 7 center in USA and 3 center from Europe, and title of the study is Safety and Efficacy of a Novel Resection System for direct endoscopic necrosectomy of world of pancreas necrosis, a prospective international multi-center trial. So why this study is important? We know around 20% of all pancreatitis will end up in necrotizing pancreatitis. And out of that, 30% will, all necrotizing pancreatitis, 30% will have infected necrosis. And out of all infected necrosis, 15 to 30%, there is mortality chances 15 to 30% out of all infected necrosis, whereas 10% in case of sterile necrosis. And over the years, there are paradigm shift in the management of this infected necrosis. That is, from surgery, now we have advanced to minimally invasive technique. That is endoscopic drainage followed by necrosectomy. And this then, that is direct endoscopic necrosectomy, till now they utilize the conventional accessories like snares, basket, forceps, and retrieval nets for necrosectomy, which is a little bit cumbersome. No grief is there, and it is difficult to take out that necrosis part into the stomach. So this novel dedicated instrument for DEN they have developed. This is endorotor powered endoscopic debridement pad. This was developed, and this was a pilot study was done on 12 patients few times back, and on and above after that pilot study, this group has done their prospective multicentric trial. That is, aim of this study is safety and efficacy of endorotor pad system for direct endoscopic necrosectomy of world of pancreatic necrosis. Few lines about the device. As you saw, this is an endorotor pad system. It used to resect the necrotic tissue. Here we can show that is A is this endorotor console is there, and B, this picture is endorotor powered endoscopic debridement catheter is there. So this catheter is motorized catheter, and it sucks got the debris using the negative pressure. And this catheter can be used in therapeutic endoscope or endoscope having a working channel of 3.2 mm. And it has 2 foot pedals so that endoscopy can endoscope, those who are doing the endoscope, they can utilize it. It can rotate at high speed, that is 1700, rotate
Lost the audio.
Yeah, it got stuck, sir.
One center in USA and 3 centers in Europe cohort study. And they have included patient who are more than 22 years, having symptomatic world of pancreatic necrosis, and who have given informed consent. And world of pancreatic necrosis of size 6 to 22 centimeter with at least 30% necrosis. And US guided transluminal drainage at least 2 days prior to the index direct endoscopic necrosectomy should have done in them. And they have excluded patient having pseudoaneurysm, intervening gastric varices or vessels, and those who are on dual antiplatelet or therapeutic anticoagulation that could not be withheld, and pregnant and lactating women are excluded from the study. So their primary outcome is safety. Safety is defined by freedom from major device-related adverse event, that is, endorotor bed system device-related adverse event through the 21 days post-necrosectomy. And secondary outcomes are clearance of necrosis, that is defined at least 70% and clearance assessed by that is contrast and computed tomography at day 21. It is total procedure time, that is scope in to scope out time, and from catheter in, that bed catheter in to bed catheter out time. Adequacy of debridement, total number of DEN procedure required, length of hospital stay, and that is patient quality of life, SF 36 questionnaire form. So these are the secondary outcomes. So little bit about the study procedure. This is first picture A is showing endoscopy view of debris in the cavity through stent. Basically, all these patients have transluminal drainage have been done in all these patients. After transluminal, minimum 2 days before this procedure, they have done transluminal damage, and they have put some plastic stent in some few patients, lumen appeasing stent or SAMs they have put. That is self-extending metallic stent. They have, most of the patients have lamps. So through the port, they have went through the endoscope into the necrosectomy cavity, and through the working channel, they put the pad catheter, and they start the necrosis and debridement of the necrosis. They start, and below picture showing endoscopic view of endorotor catheter orientation, and picture B is endoscopic view of necrotic tissue being drawn into the cutting window. So they have taken around 37%, 37 patients. Out of 37, 7 patients have been excluded because of this inclusion criteria. They could not meet the inclusion criteria. So if you will see the baseline characteristic of this patient, basically we will not go into details. Here we can see the etiology of pancreatitis, biliary pancreatitis. Most of them are biliary. And if you see stent placed, most of them stent placed are lumen appeasing metallic stent. That is 23 out of 30. And only 5 patients have plastic double pictal, and 2 patients have SEMS. And volume of collection, mean volume is around 612 ml, and percent of necrosis is around 70% necrosis is there. Most important point to note here, none had multi-organ failure. Out of the 30 patients, none had multi-organ failure, we used to see regularly in our day-to-day practice. Those who are infected necrosis, many patients used to land up in multi-organ failure. But here they have most probably taken milder group of patients. And here this table showing endoscopic assessment of percent necrosis removed from the collection per procedure and percent necrosis remaining. So if this is procedure number 1, done in 30 out of 30 patients, so 80% necrosis removed in 50% of the population. So in procedure number 2, around 70% population, around again 40% necrosis removed. So median number of procedure per patient is around 1.5, and median days of 6 days between the consecutive procedure. Important to remember, around 67%, that is 20 out of 30, required less than 2 procedures to achieve resolution. And 4 patients required 3 sessions, 2 patients required 4 sessions. So mean total procedure time is 117 minutes and mean endorotor time is 71 minutes. And overall median percent necrotic debris removed per procedure is 66%. And follow-up visit at day 21 post necrosectomy, 70% removal of necrotic debris achieved in 97% of the patient. That is 29 out of 30. If you focus on the adverse event, there is no device-related adverse event noted in all these 30 patients at day 21. Only they have noted 3 serious adverse events, that is procedure-related again, 2 GI bleeding and 1 is pneumoperitoneum. And that pneumoperitoneum patient died of multi-organ failure later on. But there is no device-related adverse event they have noted. So they have again taken the 36 item short form survey and they have seen physical functioning, emotional well-being, social functioning, and pain is significantly improved from baseline to follow-up after this procedure, then procedure. So if you see advantage of this novel tool, it is safe. No device-related adverse event have been noted. Average reduction of 85% in collection volume and 91% necrotic debris was achieved. And there is low median number of DEN procedure done in each and every patient. That is 1.4 versus the history. We say a lot of papers are there and they have around 4.1 DEN procedure required. And there is early discharge, 10 days versus 14 to 29 days of the prior studies. But there are few limitations in the studies. It is a non-randomized trial, having small sample size, only 30 patients are taken. There is lack of central independent radiologist for assessment of volume and percent of necrosis. There is subjective assessment of endoscopists regarding adequacy. And study was sponsored by device company. So these are few limitations. And there is one editorial on this journal also for this study. And they have mentioned, though this is a new study having new tool, there is lack of randomization in there, lack of central independent radiologists for inclusion as well as resolution. No patient included in the study has existing multi-organ failure. So milder group has been selected. And quality of life improvement is due to drainage of WOPN rather than being attributed to device. So main take-home points should be it's related to safety and feasibility rather than efficacy. This efficacy is due to drainage of WOPN. And on technical note, it is not clear. However, they have started the debridement from the central location or periphery. How do you they know the catheter is too deeply embedded in the necrosis? And does it help to alternate its use with other devices like snare, nets, and basket? It is not clear. So take-home points from this study is this novel endorotor pad system is safe and feasible for direct endoscopic necrosectomy, and low median number of DEN procedure required, and overall median percent necrotic debris removed per procedure was 66%. And there is Sutter Hospital say, however, randomized control trial with sufficiently power study is required before before generalizing and utilizing this novel toolbox. Thank you, sir.
Sir, Ramas.
Yeah. So, do you want to go ahead, Venkat? Do you want to say something?
No, you can start, sir.
Sure. So, I thank you, Dr. Pandegiri. That was very nicely summarized this paper. But I think basically, as you said, they've taken mild patients, they've taken non-infected patients essentially. And the reason for that is that this is a registration trial. The FDA requires, this requires FDA approval. So the FDA has specified that they need to do 30 patients, of whom at least 15 should have been in the US. That's what I think the first sentence of the thing is.
Yes.
And as you correctly specified, they've therefore taken people who don't have infected necrosis and who don't have multi-organ failure, and just looked at the feasibility, as you said, and the safety. So with all that, it's like any device. When a new device comes in, it looks good. I'm sure as time goes on, all the refinements which you have pointed out will need to be done, that it needs to be used in more sick patients, how safe it is in those people, and so on. Venkat, any questions?
The only other thing I just want to, apart, all these patients have undergone a LAM. This procedure, this tool is probably only to use it through the endoscope. Sometimes we have a lot of retroperitoneal necrosectomy, which we do through a drain, put retroperitoneally. Is it accessible through that? Can we put the endoscope and use this one thing? All these, we had lamps and we have gone through the endoscope. In case you need to do a MERP, like a minimally invasive retroperitoneal necrosectomy, we don't know whether we can use this. Can it be used in such situations? That's the only thing which I want to. Dr. Manas, you have any information on that?
No, sir. They have. This is basically they have done a pilot study on 12 patients, and this is add-on. They have on that pilot study. They have this safety and all those things. They have established again in this prospective higher number of patients. That is 30 patients only. Percutaneous, no data, sir.
Yeah, but the instrument looks pretty good. It can be used through a double channel working endoscope.
Yes, sir.
And probably we know that when we use a lot of snaring, inadvertently you may debride a lot and then patients can go for a bleeding. So, but how deep to go into it is something which we need to see whether, because many times, even when you are snaring a the necrotic material, inadvertently it starts bleeding. So we are not very sure of the depth. I think we should know about the depth. And probably, as they said, it could be a combination of just trying to slowly resolve the debris and then probably snare it out. That may be an option. As Dr. Professor Rama said, as time goes on, refinements in the techniques will come. Initially, it just happened.
So here it seems that they use. Sir, here it seems that they use suction of varying the thing to draw it inside, and then use different rotor speeds to cut it, right?
To cut it,
and that is what needs to be adjusted. I guess one has to get used to the equipment and then see what causes the least trauma.
Yes, sir.
The other thing actually which we might consider in this journal is the procedure time is around 117 minutes. So it is supposed to be something like automated thing, but still it is taking close to 2 hours per session, I guess. That's what they have mentioned. So that is probably a pretty bit long than, or it almost similar like what we do in using traditional instruments.
Possibly because it's a pilot study and they don't know how much depth they go in.
Yeah.
We are not very sure of the vascularity of these necrotic materials. So they would have been much more careful in drilling it and cutting it down. So probably you know how much depth. The second thing I was at the end of 21 days, how did they assess the residual necrosis? Is it by radiologically or they again did a endoscopic evaluation?
So all 10 center sites are there, sir. They have done it radiologically. On few patients, they have again endoscopically done.
Okay.
On endosonography.
So,
and how long did they leave the lamps? The moment it was over, they removed the lamps, or?
So that data is not in this paper, sir.
In the paper. How long?
I was kind of agreeing with Venkat sir on this. I mean, when he said the assessment of the amount of necrosis at the 3 weeks, I mean, that is very critical because you're telling us that at baseline and then comparing directly at 3 weeks. And most of these patients were clearly not as sick as the patients we usually take up for a necrosectomy. So I mean, like sir is saying, there are 10 centers and there are 30 patients. Of course, there is going to be a lot of heterogeneity in how to assess the amount of necrosis. I mean, we cannot.
That is the limitations of this.
Absolutely.
Also said.
Yeah.
Should I go to next paper, sir?
Sure.
So thank you, sir. So next paper is on ERCP. That is published in Endoscopy. This is French group has done this study, and this is early double guide wire versus repeated single guide wire technique to facilitate selective bile duct cannulation, a randomized controlled trial. Again, why this study is important? We know what is difficult cannulation. Yes, he has defined clearly. If you are taking 5 minutes, more than 5 minutes in cannulating, more than 5 attempts of tip of spindotome touching the papilla, and if more than one inadvertent entry into the pancreatic duct, then it is called difficult cannulation. And in that situation, rescue cannulation procedure are required. That is pre-cut sphincterotomy, that is fistulotomy or papillotomy. So if guide wire inserted into the pancreatic duct, it facilitates biliary cannulation because that it stabilizes the papilla and stabilizes the papilla, and the pancreatic duct opening become blocked so that the guide wire easily went into the biliary direction. And in that case, when there is guide wire is in pancreatic duct, we can pancreatic guide wire assisted biliary access can be done by various techniques, that is double guide wire, transpancreatic papillotomy, or pre-cut endoscopic sphincterotomy over the PD stand or wire. So this double guide wire technique originally invented by this Dominic et al. But after his starting, there is a lot of controversy. There is safety and success issue are there. But because of most probably they have used this technique, double guide wire technique, after repeated cannulation after short time, and they so there is fallacy there, there is bias is there, and so this group has done, that is unintentional PD cannulation, early guide wire. That is one cannulation, once the guide wire entered into PD, they have once entered into PD, they have randomized here early double guide wire group or repeated single guide wire technique. So that is the beauty of this study. And they have compared here the rate of successful CBD cannulation, time to cannulate, and rate of adverse event between the early double guide wire versus repeated single guide wire. So this is basically a randomized controlled trial, having taking in France 6 tertiary care hospitals have participated between November 2016 to November 2019. They have included more than 18 years patient with native papilla who are scheduled for therapeutic ERCP, and they are randomized after unintentional PD cannulation. One, the PD cannulated unintentionally, then only they have randomized them. If it is entered into CVD, then they have excluded those groups. And they have excluded those who are less than 18 years, pregnant, surgically altered anatomy patient, ERCP for pancreatic intervention group, PD stricture, acute pancreatitis, bleoduodenal fistula, coagulopathy, and those who are in poor general condition. They have excluded them. So 1:1 block randomization opaque envelope has been done after the catheter, after the guide wire has entered into PD unintentionally. In the early double guide wire group, here we can see once this solid line, the guide wire has entered into PD. Once that is entered into PD, they have randomized, and the early guide wire group, they have taken out the sphincterotome. Again, they have with a second guide wire, 035 guide wire, they have entered again into the sphincterotome by the side of the previous first guide wire, and they entered into the CBD. So this is basically picture depicting that. And in both the group, what they have done for prophylactic of pancreatitis, post-ERCP pancreatitis, they have pancreatic stent have been given, and previously they have analgesic interrectal indomethacin they have given. So to decrease the post-ERCP pancreatitis. So this is the patient flow chart. They have enrolled 149 patients after unintentional PD stenting. Out of that, they have excluded 7 because of anticoagulation issue, previous sphincterotomy, and one guidewire convolution, more than one guidewire in pancreatic duct. So they have randomized 142 patients, and they have allocated 142 patients allocated into repeated single guidewire group and early double guidewire group. That is 74 in RSG and 68 patients in the early double guidewire group. Out of 68, primary cannulation, CBD cannulation was successful in 57 patients out of 68. And in repeat single guidewire group, 37% has primary success, that is CBD cannulation in 37 patients out of 74 within 10 minutes. The important point here to note, success has been defined if they have cannulated CBD within 10 minutes. So they have succeeded in 37 patients within 10 minutes. After 10 minutes, they have crossover this to late double guidewire group, LDG. That is late double guidewire group. 37 patients they have done, and they have succeeded again in 26 patients. And they have analyzed 74 and 68 patients in each group. So primary outcome is successful selective bile duct cannulation within 10 minutes after randomization. So important to note, within 10 minutes. And secondary outcomes are successful final selective bile duct cannulation, time to bile duct cannulation, successful bile duct cannulation with late double guidewire and pancreatic guidewire assisted biliary techniques, post-ERCP pancreatitis and other ERCP related adverse event, and ergonomics of early guidewire. So if you'll see the patient characteristic in both the groups, there is no significant difference. Basically, if you'll see here, both the group mean age group are almost equal, no difference. ERCP indication, if you'll see again, biliary stones are most common, and there is no difference in the indication of ERCP also. If we'll see into the ERCP characteristic, CBD diameter, no difference. There is a impaction stricture in distal CBD. There is no difference in this. And biliary stent insertion, there is difference in early guidewire group, around majority 38 out of 56 as biliary stent insertion, whereas 28 in this RSG group. So if you look into the early guidewire performance and safety, so 84% success in early guidewire group, whereas 50% in the repeated single guidewire group. So there is significant difference in our primary outcome. And if you see the secondary outcome, time between pancreatic duct cannulation and CBD cannulation, there is 6 minutes here in early guidewire group, around 10 minutes in repeated single guidewire group. That is again significant. And adverse event, no difference. Type of complication, again, there is not much of difference. If you look into post-ERCP pancreatitis, those who developed versus those who do not develop post-ERCP pancreatitis, there is no difference between the number of guidewire pass or contrast injection or number of sphincterotomy passed. Basically, all of them had interrectal indomethacin, and those who had PD entered, they have given pancreatic stent also. So, management of difficult biliary cannulation while reducing post-ERCP pancreatitis remains always a challenge. And ESG recommends pancreatic guidewire assisted biliary cannulation. So this current randomized control trial shows selective bile duct cannulation was achieved within 10 minutes in 84% in the early double guide wire group versus 50% in the repeated single guide wire group. That is significant, quite significant. And early conversion to double guide wire method may reduce the risk of post-ERCP pancreatitis due to papillary trauma caused by repeated cannulation attempts. Hence, PP rate is 1.5% in this study. So, strength of the study is it is a randomized control trial, multi-centric, so we can generalizability is there. And on this study design, basically they have done, once they have entered into PD, then only they have randomized. First, unintentional entered into PD, they have randomized, which is lacking in previous studies. They have repeated cannulation, they have attempted, then only double guide wire technique they have done. That's why in this study, early double guide wire. That is the important study design they have done. And quite few limitations. Number of patients are small. Of course, because of intervention, it is an open level study and it was done in an experience center. So no trainee was involved in this study. So again, difficult to generalize in all the centers. So if we conclude, early double guide wire techniques should be considered as first approach for selective biliary cannulation in patients with unintentional pancreatic cannulation. And there is high success rate of CVD cannulation with lesser time and low PET rate. But there is large prospective studies are needed to assess the cost effectiveness and therapeutic success rate of ERCP in this group. Thank you, sir.
Yeah, this was I think ESG itself in their many of their guidelines have said that if you do not cannulate within 5 minutes, and you can always try a double wire technique. It's been practiced most of in the European places, and I was a fellow at Brussels with Jack de Vieira. That's a team which always used to go once they put in a guide wire. Once it goes into thing, they always used to cannulate with other guide wire. But I think this study has shown that using an early double guide wire technique, many of us use pre-cut. I think in this particular study, there's never been any pre-cut. Am I right?
No,
They
sir.
do any pre-cut sphincterotomy?
No, sir.
So one of the things they have said is that it reduces the PEP and also a pre-cut sphincterotomy when you use a double guide wire technique. So this is a well-conducted study, and probably it's you can avoid pre-cut and associated complications like bleeding as well as pancreatitis on a perforation when you can use a double wire technique. But again, you are going to use 2 guide wires, so we need to look at the cost effectiveness of using 2 guide wires, because cost to the patient is something which we need to calculate on this. Dr. Rama, sir?
Yeah, it's an interesting paper, Manas, and I think you presented all the pros and cons. And like you said, 5 minutes. But here, if the first time you just go into the PD, then you straight away go to a double guide wire is what they are saying.
Yes.
I mean, you could do it in the first minute itself, for instance, if it goes straight into the PD and not into the CBD. So I think that's something to consider. Maybe we should think about it and incorporate it in practice.
Yes.
So I think that's this may be good for beginners, because sometimes I see in some centers a lot of pre-cut is being used, and you don't cannulate after a pre-cut, and then you have problems with the pre-cut. So many of the European centers have really given up pre-cut. I don't know about the American centers, but many of the things are pre-cut. Even in your training as a fellow there in Europe, they don't allow you to do a pre-cut. At least you try different techniques before you get into the fight. So I think it's a good conduct study, and it seems to be quite this thing. If you can work out cost effectiveness, I think this is a very thing. It seems to be very, very safe. And the incidence of post-ERC pancreatitis seems to be less, even though you have got into guide wire once or twice. But effectively, I feel that it has reduced the chance of doing a pre-cut and your way of cannulating. Over the time, I think when you use this technique, you'll also know the direction of how which you go in when you're connected again. When you're
Yes, I think
touching a bile duct.
for sure.
You will get the direction and you will exactly hit after that area. Majority of the times when you go and bow the cannula, you will get into the pancreatic duct. But if you have a guide wire in place, you know where to go. And I think after a few successfully doing this, you may be able to do it without, because your expertise improves of the position where you get in your cannula. That's what I think I have learned. Initially, I used to do a lot of this. When it goes 3 or 4 times, it's not going in, leave the guide wire, do it. Now, I think we know where the position is and then we go in.
So this has been mentioned, sir. Nicely you have pointed out. This has been mentioned. Once the guide wire is in PD, so the orientation towards CBD is towards left and 11 to 12 o'clock. It is easy to again guide the guide wire towards CBD.
Towards the bile duct, yes.
Sir, so both the experts who, so in practice, after how many attempts, after how many PD cannulations do you actually change to a double guide wire technique?
I think that would depend on who's doing it.
These days, I think after so many years, you are more or less successful to get into a bile duct.
Yeah, I think it goes straight into the bile duct.
So you go straight into the bile duct, and you also have your experienced technician working with you for the last 25 years. So I think there also thing is there. But I think initially, if you want 4 or 5 times, I think.
Okay. Yeah.
I personally feel that we should not rush for a pre-cut. That's what I have learned during my training in Europe. Don't rush in to do a pre-cut. I've seen a lot of times pre-cut is being done. It's going awry somewhere, and patient gets pancreatic, then referred to us. Then we don't do anything for 1 week because you know that the whole thing is this thing. But this technique seems to be that. That's one important thing they pointed out in the study is pre-cut has almost been eliminated by doing this study, and you have a very effective sphincterotomy of these things.
So one of the interesting things, sidelights, which they point out is it was the repeated single guide wire which had 100% eventual success.
Yeah.
The early double guide wire had some instances where they did not have 100 eventual success.
So basically what they have done in repeated single guide wire groups, sir, those who are primary endpoint within 10 minutes, they have not successful in CBD cannulation. They have crossed over to early double guide wire.
Okay. No, they crossed over to pre-cut, they crossed over to pancreatic duct sphincterotomy and so on.
Yes, sir. So overall 100% success in that.
Yeah.
That's what I think that is what something. That's what they have done. So they have done almost even once it went to pancreas, they have got into the early double guide wire. And people, when they were not successful, even the late guide wire technique was successful in cannulating the bile. Am I true in this?
Yes.
Yeah.
And they have said for the second one, use a straight hydrophilic guide wire to get into the bile.
Straight hydrophilic 0.03.
Yeah, they said you use a straight hydrophilic guide. That's what the study said. Put a straight hydrophilic guide wire to cannulate the bile.
Should I go to third?
It's a good, nice study with a lot of takes in this.
Please.
So this is our third journal, that is on colonoscopy, and this is again published this month in Gastrointestinal and Endoscopy from Korea. This is done in Korean population, and title is Efficacy and Safety of Split Dose Bowel Preparation with 1 liter polyethylene glycol and ascorbate compared with 2 liter polyethylene glycol and ascorbate in a Korean population. A phase 4 multi-center randomized endoscopist blinded study. So why this study is important? We all know bowel preparation is the most important and worst part of the colonoscopy. And the ideal bowel preparation as an which is ideal, which is effective, so we can clearly see the mucosa. It should be safe without any major adverse event, and it should be well tolerated. And we know what is the issue with recommended now. What we are using nowadays, recommended by US FDA also, this bowel preparation agent, that is PEG-based regimen. So volume compliance is a major issue in this group. Around 2 to 4 liter of PEG-based regimens are consumed before colonoscopy. So this 1 liter PEG-based bowel preparation agent, that is Plenbu, was introduced, and there are few RCTs in America and Europe which showed this overall bowel cleansing efficacy, compliance, tolerability, and safety is better with this 1 liter PEG in comparison to the 2 liter PEG. But there is no data from Asian countries. So this group, this Korean group, has done this study, that is phase 4 multicentric colonoscopic binded non-inferiority randomized control trial, and they have done in 9 tertiary referral hospital in Seoul, and from February 2020 to September 2020, and they have included men and women from 18 to 80 years undergoing screening, surveillance, or diagnostic colonoscopy. They have excluded those who have history of colorectal carcinoma, inflammatory bowel disease, surgery, pregnant or breastfeeding women, and those who are have renal insufficiency, those who are prior colonoscopy within 6 months, or those who are in another trial within the 6-month period. And they have randomized them into 1:1 into one group into this Plenbu, that is 1 liter PEG, and Clicul, that is available in Korea, that is 2 liter PEG plus ascorbate. So basically, they have given their supplementary table, the constituents of Plenbu, that is 1 liter, and Clicul. And here we can see that the total volume that they have consumed in this Plenbu group, that is 1,000 and 1,000, that is 2,000, because they have taken in a split dose preparation, 2,000. And in this Clicul group, around 3,000, that is 3 liter. 2 liter consumed in this 1 liter PEG-based regimen, and 3 liter in this 2 liter PEG-based regimen. So this is the study flow diagram. So they have screening and randomization done prior, and on the day before colonoscopy, they have taken, one group has taken 1 liter and another group has 2 liter PEG. Then on the day of colonoscopy, again they have taken the split dose regimen as per US FDA, and they have followed them 10 days for safety. This is the patient flow chart. They have enrolled around 362 patients. Out of them, 2 didn't give consent, so withdrawal. 360 patients randomized into both the group, 180 into Plenbu group and 180 into 2 liter PEG group. Then you excluded in the 5 excluded in the Plenbu group, so 175, 8 excluded in the PEG group because they didn't take those preparations. So 175 and 172. Then they one didn't have this Boston bowel preparation scale report, that is efficacy cannot be ascertained. So they have again excluded the patient. So 174 and 172 in the modified intention to treat analysis. And after that, some protocol violation has been occurred, and as per protocol analysis, 159 patient in the Plenbu group and 162 in the 2 liter PEG group. So how they assess, the experienced blinded colonoscopist assessed, they have done the colonoscopy, and Boston bowel preparation scale has been used to assess the bowel cleansing success rate and high quality cleansing rate. And adverse events were assessed at OPD basis or telephone call on the day 10 after. So their primary endpoint is overall bowel cleansing success. That is Boston bowel preparation scale score more than equal to 2 for all segment of the colon. Basically, they have given this scoring system in the supplementary table also. So this Boston bowel preparation scale, they have 0, 1, 2, 3 for each segment. So total score is 9. So it is ascending colon, transverse colon, and descending colon. So if you will combine each and every score, that is overall score is 9, and for each segment highest score is 3. So they have primary endpoint is overall bowel cleansing success, that is BPPS score more than equal to 2 in all segment of colon. And secondarily, they have examined segmental bowel cleansing success rate, that is again BPPS score more than equal to 2 in each segment. They have examined high quality bowel cleansing, that is overall 9 and segmental 3. Polyp detection rate, adenoma detection rate, tolerability, acceptability, compliance, again defined by more than equal to 80% of each dose they have taken, satisfaction and acceptability of test and volume. So these are the secondary endpoints. If you look into the result, this patient baseline characteristic, there is not much. They have given here demographic, that is age, gender, weight, BMI, and medical history. Not much difference between the both group, Lenvo group and 2-liter PEG group. No difference. Again, this laboratory data, few hemoglobin, LT, AST, creatinine, and indication, there is no difference between both the groups. They are equal, sort of. And you'll see that in the result, that is primary endpoint, overall bowel cleansing efficacy. Here we can see in this graph that is there is no difference between the Plainview group and 2-liter PEG group. You will see successful overall bowel cleansing, and there is no difference between the overall bowel cleansing efficacy on the segment wise also, right segment, transverse, and left segment, and same in the per protocol analysis also. There is no difference between the Plainview group and 2-liter PEG group on overall bowel cleansing efficacy. If you see segmental bowel cleansing, there is overall high quality bowel cleansing in the Plainview group, and that is significant difference is there in overall high quality in overall and right segment colon. However, there is no difference in the transverse and left segment. Similarly, in the per protocol also, there is significant difference in the overall high quality bowel cleansing in overall and right segment colon. If you see into the polyp detection rate, again there is significant difference in the per protocol and modified intensity group between the Plainview and right side colon, and there is no difference in the adenoma detection rate in Plainview and 2-liter PEG group. So if you'll see into the overall satisfaction, there is no difference between the 1-liter PEG versus 2-liter PEG group, but there is volume acceptability in the Plainview group, because this Plainview group people have taken around 2-liter, total 2-liter of fluid before colonoscopy, whereas the 2-liter PEG group has consumed around 3-liter fluid. So there is volume acceptability in Plainview group, and that is significantly showing difference. Whereas test acceptability, this Korean population have given more score to this 2-liter PEG group, and there is significant difference, and they have preferred this 2-liter PEG over this 1-liter PEG regimen. So again, adverse event, if you'll see, there is not much of difference, but total adverse event number is more with the Plainview group. That is significantly different, but they are basically milder adverse event are there. If you'll see into adverse event, nausea is more common in Plainview group, that is 1-liter regimen, whereas abdominal distension is more common with the 2-liter PEG group. Of course, because of volume and all those things. So in this trial, 360 SCN participants, Plainview showed a non-inferior bowel cleansing success rate to 2-liter PEG, that is 93% versus 91%, no difference. And strength of the study is it is a multi-century randomized control trial where colonoscopists are blinded, whereas limitations, colonoscopy indication and previous colonoscopy experience is not identical, and there is no central readout for this BPPS scoring system. However, they have taken a training session, those who are participated in this colonoscopy step, they come to a conclusion before entering into the study. They come to a conclusion. Training session is done on this BPPS scoring. And so to conclude, 1 liter PEG preparation was non-inferior bowel cleansing success rate, high quality bowel cleansing for overall colon and right-sided colon with high polyp detection rate, and there is no adenoma detection rate, no difference, and there is high volume satisfaction. But adverse events were more in 1 liter PEG group, but it was mild. That is, nausea and vomiting are more in 1 liter PEG group, but abdominal distension more in 2 liter PEG group. So they have advised to take slower intake of this 1 liter PEG based solution to avoid this nausea and vomiting adverse effect. But before there are multiple studies required from the Asian subcontinent for generalizability of this 1 liter PEG based regimen to be used for colonoscopy bowel preparation. Thank you, sir.
Ramas, sir.
Yeah, thanks, Manu. So I think that was a fairly straightforward study. And you've summarized the strengths and the limitations. And I guess it has to differ in each population because colon length and colon content is different between populations.
Yeah, transit also.
and transit. And of course, the colon content is also dependent on transit, I guess. Also, it probably depends on the indications. I don't know if many of the people who were the Koreans who were entered into this trial were undergoing things like screening colonoscopy, or whether they actually had disease, like Crohn's disease or tuberculosis or colon cancer. So whether it will vary depending on that and depending on obstruction, those are other issues, I guess. But yes, I think that's so the trend is towards a lower volume supplemented with fluid, because the 1 liter also you have to take additional 1 liter of free water along with that.
I think the ascorbic acid is generally added for the palatability. If you look at the bowel preparations, elementally when you got in this polyethylene glycol, you are recommended to have 2 to 4 liters actually. And if you are not able to take that 4 liters, they were even said that you need to put in a rice tube and give a slow preparation. That was earlier what was really thought, because unless the key for a bowel preparation, as either you go by the Anoshic score or Ottawa preparation or the Boston preparation, is your cecal intubation rate and detection of polyps. So they have found that the more cleaner the colon, your dissection is. Of course, the only problem is the other 2 scoring systems are before the colonoscopy, and the advantage of the Boston is that you suck and clean and then score the preparation during the procedure. That's one thing. So many things have been added for the palatability, number one. So one of the things they added was ascorbic acid. Then there's some of the studies have shown that when you when you mixed this preparation with the Gatorade, that sports drink, there was more acceptability and palatability. And some people even said that the low calorie Coca-Cola was also used. But FDA has not approved the use of Gatorade in these preparations, number one. Number two, the key is that when they had the acceptability, they were they were able to take the lower amounts, and lower amount of taking this preparation had more acceptability of the patients and better colonic preparation. That's what I think is a study in here. So now when you wanted to really want to have a low volume preparation, there was this move from polyethylene glycol to sodium phosphate, sodium picosulfate, and that particular group, of course, with a black box warning for sodium phosphate. So now they've added sodium sulfate, sodium picosulfate, where you could probably use 1 liter, as you said, or 2 liters, and then have an adequate bowel preparation. That's what I think. So the adding ascorbic acid has really increase the acceptability of taking this and improve your preparation and compliance of the patients. So when they had a good, better preparation, your adenoma detection rate was higher and your cecal intubation was time was shorter and it was higher. The other question is, before colonoscopy, is there any role for the diet? Should we take a low residue diet? Should we do a clear liquid diet before colonoscopy? Is something which we need to answer apart from the preparation. But I think there is not much of a difference whether you take a low residue diet. In fact, people who take low residue diet were better compliant with this preparation than patients who took clear liquid diet. That's also one thing. And we don't have any guidance to say what is the low residue diet in these patients. That's the third thing. And the other thing is, these days in the bowel preparation also, when we use a low prepared, with the use of AI, artificial intelligence, also has increased the efficacy of scoring the bowel preparation plus pickup of your adenoma rates. Any of your comments on that?
So, like in actual practice, I think Dr. Venkat has mentioned a lot of things. We tend to use the sodium sulfate, potassium sulfate, magnesium sulfate, and that it's a low volume. It tastes a little very metallic, but most patients do accept it. And as far as we are concerned, I think we've got very clean colons for the procedure. So there's also these issues. I mean, earlier with the polyethylene glycol, in CFC the nurses used to ask them to get a bottle of Fanta or liquor or something and mix it up with that and drink it. So there are many strategies to improve taste, I guess.
Is there any comment on split dose preparation versus same-day preparation?
I think the present recommendation, is split is better. You take, but only thing is the inconvenience of patient getting up. They say by the end of your preparation, the colonoscopy should be 4 hours. So if you are having a colonoscopy at 9 a.m. in the morning, then the patient has to get up at 2 a.m. and then probably finish it off, or 3 a.m. and then finish it off. That's one thing which I found it to be. Some people are willing to get up at 4 and have it and then come and have it at 9 o'clock. But if you're going to do it under, say, for a patient who has got a cardiac problem under deep sedation, then the anesthetists want you to have at least a 6 hours gap between the last drink and your anesthesia. So there's only the timing is, but essentially split volume seems to be better than a single day preparation. That's what has been, the studies have shown split volume is better, except the compliance of the patients.
In real life situations, sir, one person has taken split dose, half of the dose at evening, previous day before colonoscopy.
Yeah, so, the next day is early in the morning.
Unable to sleep at that night.
That night, that's all. They will get up early in the morning and then again have
Actually, we give our patients between 5 to 6 or 5 to 7 in the morning, and they are well prepared. By the time it's 10 or 11 to have a colonoscopy. For most of our patients, it works out. But as Venkat said, there are some instances where we have to go a bit slow.
But split is good. Split, actually, I feel it's good. When you have done a split, the colons are much, much better. There is a nice article which came up in gastroenterology reports. Bowel preparation for colonoscopy. Past, present, and future. That was something in 2020. I said sometime back I read, but I think it is. And at least you should have a Boston preparation score of more than 7 to really pick up increase your adenoma detection rate. But let's say it'll be interesting once the AI comes. What happens to your ADR? Even in the presence of little suboptimal preparation.
Actually, AI may be having a lot of false positivities in that sense. Like if it is not clean, whatever is there is a slightest protrusion on the mucosa, it's going to show it up. Like I had the opportunity to work on the near Olympus model, but there are a little bit of false positives, especially with the small bits and pieces of stool. But still, we need wide experience on that.
There was an ESG webinar on this, AI in colonoscopy. Very, very good study that this is by the Italian group which did it. And I regularly attend the ESG webinars. They're very, very good. They've shown one thing about AI is at least it will tell you if your colon is not well, it will tell you that there may be a polyp. So you may have to clean it again and then because their CRC rates are high. And that's one thing which they said. More than the false positives, it may say that, well, you got to be careful that there may be a polyp underneath so that you spend some time there, wash it and then look into it. That's also one thing which they have very well seen. What's his name? He's a very, he's from Italy.
Dr. Repici.
Repici, correct. Repici and the other guy is Hassan. Caesar Hassan. So this one of these webinars which comes on a Wednesdays. So when you do it, that's what they said, that at least it will tell you that there's an underlying polyp and you got to be careful, or you may have to re-prepare and do this patient. You cannot get away with that. That's one thing which they said about AI in these patients.
Could you move, sir?
Yeah, sure. Thank you.
Thank you, sir. So the fourth one is on EUS that is published in Gastroenterology 2021. And this is endoscopic ultrasound guided fine needle biopsy with without rapid on-site evaluation for diagnosis of solid pancreatic lesion, a randomized controlled non-inferiority trial. So why this is important? We know US FNA, that is fine needle aspiration with ROSE, is an efficient diagnostic modality for evaluation of solid pancreatic lesions. We know the advantage of ROSE is that there is simple adequacy and optimizing the number of passes. However, over the recent time, by the development of new generation needle, had high histologic and diagnostic yield. And there are a lot of data which shows that US FNB is somehow equal to US FNA plus ROSE. So whether ROSE can improve US FNB performance for diagnosis of solid pancreatic lesion is still now unknown. So the hypothesis is that US FNB alone was non-inferior to US FNB plus ROSE. So with this hypothesis, they compare the diagnostic accuracy of US FNB alone versus US FNB plus ROSE, that is ROSE with touch imprint cytology in patient with newly diagnosed solid pancreatic lesions. So this is a multicentric, around 14 centers participated, randomized non-inferiority trial done from April 2018 to September 2019, where they have included consecutive patient with solid pancreatic lesions referred for US, and all of the patients are more than 18 years and the lesion likely to visualize and sample by US, and they have given consent. They have excluded the patient having bleeding disorder and concomitant anticoagulant use, and those who have INR more than 5, those who have platelet less than 50,000, and lesion having 60 component and pregnant patients. So a little bit about the procedure and specimen processing. They have not included any trainees. Expert endosonographer have done this procedure. And on the selection of needle, that is 22G Sarcode or 22G Equer or Procore, 20G Procore, or sampling technique, that is suction, slow pull or weight suction, it is they have given the discretion to the endosonographer. The decision is final of the endosonographer who is doing that. And for ROSE technique, they have applied touch imprint cytology. That is, they have taken the FNB sample, put in a slide, and they press and rub the sample over another slide so that the superficial tissue can transfer to other slide. And the tissue core was taken to the formalin-based vial. So this is basically touch imprint cytology. And they have maximum 3 passes in each arm. and those those solid pancreatic lesions unable to puncture were excluded from the study. So primary endpoint is diagnostic accuracy, that is percentage of sample lesion that correspond to final diagnosis. Their secondary endpoint are safety. As per ASG, adverse event were assessed at day 3 and 14 post-procedure. Positive core procurement defined by intact piece of tissue of at least 550 micrometer. Time of sampling procedure and sample quality was noted. So this is basically patient flow chart. Out of 845, 45 patients are excluded. There is no pancreatic lesion in US. Biopsy performed using 25 gauge needle, so excluded. Cystic lesion are found. Declined to participate. So around 800 patients left, and they are randomized and allocated into FNB plus Rose group and FNB alone group. Out of this FNB Rose, again 15 excluded, so modified to intention to treat analysis population 385, and in the FNB alone group 386. If you see the demographic profile of the patient of both the group, there is no significant difference between the both the group. Here, most important to note is both group A's are equal, around 60. They have no difference. No difference in the needle type used, that is site fenestrated fork tip or Franzen tip. Lesion site and lesion size are also no difference. And if you'll see that sampling technique, there is no difference. Number of passes, again 3 passes they have predetermined it. There is no difference. Final diagnosis, adenocarcinoma in majority 80% and 78.8% in the FNB alone group. So there is basically no difference between both the groups. So if we see the diagnostic measure of UNFNB plus Rose and USFNB alone, you can see here accuracy. This last row you can see accuracy, there is no difference. It is 96.4% in USFNB plus Rose, where it is 97.4% in USFNB alone group. So sensitivity, specificity, NPPV and NPV, there is no much difference between the USFNB plus Rose and USFNB alone group. You see into the adverse event, there is no significant difference. Poor procurement again, but there is significant difference in the time of sampling. That is 17.9 minute in Rose group, whereas alone group, USFNB alone group, it is 11.7 only. So basically, less time is required in USFNB alone group. And tissue quantity, again, there is no difference. Blood contamination, no difference. So if we compare again the needle type, so this end cutting needle, this acquired 22G is they have better core procurement than the 20G needle, site fenestrated needle. So that is the difference between needle type. So Rose increased the diagnostic yield in USFNA, we know that. However, after development of this new generation needle, USFNB have score over USFNA for diagnostic accuracy. And USFNB here in this trial, we have again seen that USFNB was not inferior to USFNB plus Rose for diagnostic accuracy. So this is a multi-centric randomized trial having large sample size. That is the strength of this study. Whereas few limitations, pathologists are not experienced or having limited experience on this tissue imprint cytology technique. And these studies are taken in a highly experienced center, so difficult to generalize this result in other center. Non-randomization for needle type has been done, and sample size calculated for only the primary outcome, whereas secondary outcome, time and all those things, needle type, sample size are not adequate. So to conclude, the patient with solid pancreatic lesions, the diagnostic accuracy of USFNB alone with 3 needle pass is 97% and was non-inferior compared to USFNB plus Rose. So ROSE should not be routinely recommended, and USFNB should become the standard of care in solid pancreatic lesion evaluation. Thank you.
Thank you, Manas. I think this kind of reflects the general thing. I don't know what the practice is everywhere, but I think once we moved from FNAC to FNB, we've dispensed with ROSE. We had ROSE initially, and then we've dispensed with ROSE. But this is a very nice comparison. As you say, it doesn't randomize for the technique that you use in the biopsy. So whether you use a wet aspiration or a dry aspiration and a slow pull, it doesn't randomize for that. I don't know what Venkat has to say about this, but it makes sense that ROSE is not going to add very much to the adequacy here.
Like, I have not been doing endoscopic ultrasound in my unit, but two of my colleagues who do, they were doing ROSE initially. I think they were more circumspect whether they had the material available that time. Was there a cellularity there? So they used to look into that and then go ahead. Now, as you said, sir, they are 8 years into endoscopic ultrasound now. With the good needles, they are now going more for FNB rather than FNAC. FNAC we do, but predominantly depend on FNB, and we use that. One of the needles which have come from Microtech. I don't know what is that needle. Is it?
So the interesting thing here was that the Procore was not as effective, and I think most of us probably will use the Acquire needle. The Sharpcore is also now available. Haven't tried it yet though. But in this study, it was associated with more complications. The Sharpcore.
And for some time, we could not do ROE because of the logistic problems. The technician was not available. Now they got used to it doing an FNB, and then probably now we do more of FNB. They do FNAC and FNB, but we depend more on FNB for our diagnosis.
So FNB, after this FNB needles, pathologist can see later on also, and the ISC technique can be, they can use the ISC.
You can use it, yeah. ISC can be taken with FNB, yes. So more or less now practice has been FNB in our center. I think it is just the evolution of the needle. Initially, FNACs, when they were doing it, they were all very wary whether there was a cellularity or not. So they used to have something like a ROSE. This one took the impurity, say the cellularity. The cellularities was not that they again used to go and have a pass. Sometimes they used to think, but I think over the years with the availability of the needles and your expertise also. Okay.
The only advantage of ROSE in the current era of FNB would be giving an immediate diagnosis to alleviate the anxiety of the patient or communicate to the primary care physician or oncologist like that. But at the same time, if studies address the cost-effective analysis like about these things, that may actually help in changing our practice of giving it up altogether.
Actually, Dr. Chalapati, normally we get our results the next day. So pathology results come the next day. So for us, it's a matter of, I agree with you, you're right. I mean, when we were doing FNAC with ROSE, they will immediately tell you if there's a granuloma, and you can tell the patient, yes, this is a granuloma, it's nothing to get worried, that's all.
Yeah, that's quite quick, sir.
Only the IHC is required. It may take another 2 days because they need to, but next day we'll be able to get the even the FNB. Within the next day we should be able to get.
Okay. So actually, we have one question from the chat box. So this is regarding the double guide wire technique. Dr. Udvesh was asking does the type of papilla does it guide the choice between early pre-cut and an early double guide wire? So that, I think that's an interesting question. Would any of the panelists take up this question, please?
Sure. So, unlike Dr. Venkat, I favor pre-cuts if I cannot get them. So, usually, as he says, once you're experienced, you normally get in straight into the bile duct. If I fail, I prefer a pre-cut. I mean, that's my choice.
I would like to try for some time, and now I usually. It's basically that in my fellowship I was just refrained from doing a pre-cut, so that's what I think I would think. But I think this double guide wire technique has given us some advantage of the early practice to put in your cannula right into your position. And the study also has shown that the incidence of pre-cut has come down with double guide wire technique. And pre-cut, I think Rama sir will agree with me. You got to do it very carefully. You can't just. Many people just cut the direction goes. They have a bleeding. They stop it. Then they come back, and you can't see anything with that. So that's my view on that. I'm not very sure this ampullary size or ampullary position really makes a difference whether you need to put a guide wire or a pre-cut. I don't think that your inability to cannulate is one will be your guidance for a pre-cut or a double wire technique.
No, I think what the study is telling us is when you're doing the ERCP, if your guide wire goes into the PD, keep it
just
there.
Leave it there and dive.
Guide wire into the. Okay, that's what the study is.
That's what the study says.
Yeah. Avinash?
Yeah. First of all, thank you, Dr. Manas, for excellently compiling all the 4 articles. And all 4 of us, we are extremely grateful to our beloved professors for accepting our invitation to be part of this month TME. We are grateful to Rama sir as well as Venkatakrishnan sir. And we are also thankful for all the postgraduates and all the consultants who have joined. Please also stay tuned for us in the next month in endoscopy for again exciting session by Dr. Sridhar Sundaram, which is going to be on April 24th, 2022 at 5 to 6 p.m. Yeah, thank you one and all.
Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thanks. Okay. Thanks, Avinash. Thanks, Dr. Manas.
Thank you, sir.
Sridhar, Dr. Chatterjee.
Thank you, sir.
Thank you, sir. Thank you, sir.
Meet again sometime. Okay.
Sure, sir.
24th, April 24th.
24th. We'll send the invitation.
Yeah, I'll come.
Thank you, sir.
I'll just.
Yeah.
Thank you all.
Yeah.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.
Ravi, I think recording stop कर सकते.
Stop recording.
ठीक.
Ravi ji, stop recording.
Yeah. Can we stop the recording, please? Yeah.
Yeah, I think it is stopped. I think.
Okay, recording is stopped. Ravi?
No, it's still on.
I am checking, sir. I am checking. I am calling.
Okay. Yeah.
Still it is going on. I think.
बंद कर दो भाई recording.
Dr. Manas, you can keep some commentary post session.
ये भाई और मत करो. मैं with your pressure ना, with all 3 ना, मैं 3 से 4 आ गया. 3 articles से 4. Very difficult for me to again.
नहीं, तुमने आज दिखा दिया कि इंसोनियन होने का मतलब क्या है.
नहीं यार, ऐसे नहीं.
आर्टिकल को ऐसे डिसेक्ट किया कि हमको छोटे छोटे नर्व और टिश्यू भी दिख गया सब. Microscopic dissection.
Very difficult to cover 4 articles in a 1 hour. Na?
Yeah.
Of course.
I'll just come.
Yeah.
So, recording, please stop. We need to discuss something.
Arvindji, is it stopped recording? Sir, I think so, sir. It is not display. Just now I spoke to you.
That red button is still now glowing. I don't know it is recording or not. I don't
It
know.
is actually recording.
It is recording, sir. Still it is recording. Again, I will call him, sir, again. Wait 2 minutes.
Yeah.
So this time we reached 97
Yeah,
participants.
that's a good
Good number, because I'm just seeing other webinars, no? They're hardly crossing 15 to 20 these days. Hardly.
It is difficult because webinar में अभी लोगों का interest थोड़ा कम हो रहा है, but we have to keep pushing. वही है.
Yeah, that's right. I mean, in that way, I think this will be completely novel, because new things coming up every month, no? That keeps up the interest. Otherwise, it will be the same pancreatic necrosectomy, same IBD, the printing and all the stuff. So anyway, bye. Recording बंद करो भाई.
कल के सेशन में किधर भाग के ये किया तुमने, इंट्रोडक्शन किया कल भागते हुए देखिए सबको
मेरा.
हाँ, कल के सेशन में
वो डायनेमिक आदमी है, हॉस्पिटल में दौड़
रनिंग अराउंड इन स्क्रब्स इन दीस स्क्रब्स.
Please delete it from the records.
नहीं कर देंगे वो एडिट.
हाँ, एडिट कर दो भाई.
Technical team, please stop recording.
So actually, the idea of staying back is.
Can we join again in this?
I think so. Let us.
So if we join back also, it will start recording automatically, sir, because settings would have been automatic recording is on.
So anyway, I think you will edit at the end, no problem.
Yes, sir, we can edit this. We can edit this. Once we get the recording, we can edit and upload. No issues.
Right. No, the idea is just to be, more over ambitious to improve the attendance. That's the only thing. But because we are sure that there are, far many more, audience that we can reach out to, especially the PG center. So how to improve? One suggestion actually that we had from Dr. Avinash actually last time we were not able to do till now is post the minutes of the meeting for each article, so that those who have registered, the organizers will reach out to them in next 2-3 days, and then they will circulate the comments. That will be like a follow-up mail, so that those who missed out can get it. So that is one thing. Second thing, what Dr. Avinash I think suggested last time is to circulate the articles during invitation itself, pre-meeting. So that is also a good idea. I think because anyway our people are selecting these articles almost 10 days ahead. So I think these things can be circulated along with an email that so and so articles are going to be discussed, and you can also join, because there are few comments from or feedback from the audience that our session is too fast. So to cater 4 articles in 1 hour, it's not so easy. But this format looks very good, like endoscopy 1 article, colonoscopy, US ERCP, like that. Sometimes we will not be able to find it, but still, we are at least finding it. So I think if they go through these articles at least beforehand, they will have an idea of what we are discussing, like that, right? That I think these 2 things, if we do pre and post, might boost up our audience number. Anything else? Any other suggestion that?
Yeah, I think these are good ideas. This will actually help. Only thing outreach कैसे increase करने का वो सोच रहे हैं, because this will of course increase attendance. I'm just wondering how to get more people engaged, because I'm just wondering why. I mean, we've had a virtually stable attendance, right? I mean, it's I think anywhere between 90 to 100. It's always been the same. Yeah. So I mean, how to cross that 100 ka barrier is
आज three short of 100 हो गया.
हाँ वही बोल रहा हूँ यार 3
सर 100 हो गया सर. हेलो
100 का barrier 120 130 हो सकता है, आराम से हो सकता है.
आज वो
Maybe students का नहीं है शायद.
So how much is today's attendance final?
सुन रहा?
Final is 100 sir. Actually 1 or 2. One is our both are our colleagues. If you remove that, 100 is.
Okay.
I had put it up in the CMC group. So I told them like alumni are presenting, so please log in. Like we need to increase the number. So like even that feedback came from CMC only. So like basically like because we are relatively faster, in 7 to 8 minutes we are completing an article in endoscopy or gastroenterology. So they were like it is too fast, and when it moves, like only that key points we are taking, like we are not seeing the this thing. That's the reason they were requesting that if at all beforehand the articles come to us, definitely 50% may not go through, but remaining 50% they may see 1 or 2 articles, and those articles at least they will get involved. So unless